Hello, my name is Chioma Torres, and I'm a Development and Behavioral Pediatric Fellow at University of Michigan and former Michigan LEN trainee from 2020 to 2021. And it's truly a pleasure to give this talk today. So thank you so much for inviting me to talk on the topic called Disparities in Diagnosis and Management for Children with Autism. I have a specific interest in inequities in children with disabilities, but autism disparities has affected me as a mother personally, and many of my friends and family as well. Though I have many stories, and I think they are important to hear, I decided to really focus on the literature in this talk. It may offend some of you that I use Black and white in this PowerPoint, and that's not my intention. Black is how I identify myself, and the word I feel most comfortable using for that reason. However, there may be other studies presented here using other terms. So my objectives are to identify the disparities in diagnosis of children with autism and recognize the impact of racism and identify strategies to address the disparities. I want to start with acknowledging the latest CDC data that there is no overall difference in the year 2020 in the number of Black children identified with autism compared to white children. This is important for setting the stage for these disparities, which were initially partially attributed to the larger number of white boys compared to any other race and gender. If you recall, specialists can reliably diagnose autism as early as 18 months, and characteristics can be recognized as early as infancy, with many parents bringing their concerns to providers at 12 to 18 months of age. And as we know, studies show early detection and early intervention greatly improves outcomes. On average, we are diagnosing children around age 4 in America, and this is already 2 years behind what we want it to be. Black children are diagnosed 1.5 years later. A few studies have found the average age of diagnosis for Latinx and Black children are about 8 years old. Girls are diagnosed on average by age 6. Children with lower socioeconomic status or from disadvantaged neighborhoods were less likely to receive a timely autism diagnosis too. And Black children were more likely to receive another diagnosis before their autism diagnosis. You may argue that it could be white children have more severe symptoms, but the literature shows parents report more severe autism symptoms for Black, Latinx, and those living in poverty. There is discussion that girls are diagnosed later because girls tend to have more imaginative play and less stereotype behaviors, but studies have found girls have more problems forming and maintaining relationships compared to boys, and may have more acceptable special interests that are less unusual. This is a graph from Mendel's study showing how Black children were 2.6 times less likely than whites to receive the autism diagnosis at their first specialty care visit. So this graph shows in the Black column, the Black children were more likely to be diagnosed with conduct disorder, adjustment disorder, and cognitive disorder compared to white children. I want to pause for a minute and let that sink in, because conduct disorder is not a trivial diagnosis. In my years in pediatrics and DBP, I have never diagnosed this. And if you look at the DSM-5 criteria for this diagnosis, children need to have aggression and cruelty toward people or animals, destruction of property, theft, and violate rules. You can see a diagnosis like this puts children down an entirely different path in life compared to an autism diagnosis. This table from Mendel's study is showing logistic regression with the diagnosis other than autism on the first specialty mental health visit. Here you can see Black children have the 2.6 odds of receiving another diagnosis compared to white children. And you can also see the Medicaid eligible children for more than 1 year had 3.4 times the odds of receiving some other diagnosis compared to those who were Medicaid eligible for less than 1 year. Another study showed Latinx children were diagnosed 1 year later than non-Latinx children, but remember that study finding that the average age of diagnosis was 8, and that also exists in the literature. Limited English has been thought to be linked to these later diagnoses for Latinx children. Also, foreign-born children or children born to foreign mothers have later diagnoses compared to white children as well. In Mendel's studies, they've discussed there may be differences in child presentation or parent-reported behavior or symptoms, which explains this disparity. But this timely study in the Journal of Autism and Developmental Disorders from April 2021 shows the clinical presentations of children were similar regardless of racial background. This is one of the reasons healthcare professionals use to explain this disparity, which I've personally heard many times, that Black children must present differently, or their parents report different symptoms, and this is why they are diagnosed later. So these studies are important to acknowledge this is not the case, and something larger is behind this disparity. So now I want to switch gears to intervention and management disparities. This article came out during the early part of the pandemic and really put a spotlight on disparities. It is a systematic review of 11 articles which found treatment disparities exist in regards to access to care, referral frequency, number of service hours, and proportion of unmet service needs. Evidence revealed that racial and ethnic minority groups and children from low-income families with autism have less access to acute care, specialized services, educational services, and community services compared to higher income and white families of children with autism. Several studies revealed disparities such that Black and Latinx families and those of low-income households reported lower quality of care too. I'm going to go through these findings a little deeper. If a parent has an education less than high school, their child is more likely to have, or less likely to have an IEP, OT, ABA, and autism-specific therapies. I just spoke with a mother yesterday who is also a teacher and very familiar with the system, and she remarked to me how complicated it is for her to navigate the system for her child, even though she's aware of the process. She also noted how difficult this would be for someone who is less familiar. In general, racial and ethnic minority children with autism were less likely to have access to and use healthcare or treatment services. Latinx children with autism with language barriers had difficulty using services. There is a lag between Black and Latinx children between their diagnosis time and when they actually start services that's larger compared to white children. And they also receive fewer autism services. Black and Latinx children had lower use of specialty services and procedures as well. And this finding is pretty concerning because we know children with autism have higher risk of seizures, sleep disorders, GI complaints, mental health illnesses, mental health concerns. And this study found that Black and Latinx children were referred less to these specialties, and they also received less procedures once seen by these specialties, such as sleep studies, EEGs, brain MRIs, neuropsych testing, and GI studies. So differences in referral rates and referral follow-through was seen. Latinx children were less likely to receive an IEP, OT, speech therapy, and autism therapies and respite care compared to other races and white children. Other races and nationalities are more difficult to find in the literature, but Smith's study did find some data on Asian American children with autism receiving OT and speech therapy less than white children. Lower socioeconomic status is associated with lower use of healthcare services, receiving referral less likely to have a personal doctor, less likely enrolled in ABA, fewer ABA hours, and receive later and less continuous care. Other disparities are geographic, such as children in rural areas are more likely to travel to urban centers for care. And if the children had comorbidities, they tended to use the emergency room more often. Smith found no evidence of disparities once the intervention was given or ineffectiveness of services, but Black and Latinx families reported lower quality of care, stating they did not receive information, they did not receive family-centered care, and they did not have enough time spent with them. Even more interesting is that this lower quality of care has been seen in studies back in 2012, and repeated studies since then have found this association to be persistent. I added this slide because some of the children with autism that I've spoken about will grow up to become adults who fit into the category of adult developmental and intellectual disabilities. And this study shows they will continue to have poor health outcomes because of their race. This is a systematic review and meta-analysis from Yin showing how racism is related to poor health outcomes and poor mental health outcomes for adults with intellectual and developmental disabilities. The blue and red bar are the Black and Latinx adults with disabilities respectively. And you can see, compared to the green bar, which is the white adults with disabilities, they have poor health outcomes and mental health outcomes. So I have a few ideas to help with the problem, but I want to say that systemic change is not my area of expertise, and I welcome input from others. I started learning about cultural competency very early in my career, but only recently learned about cultural humility. Even if the underlying idea is similar, cultural competency with the nomenclature signifies that one can be competent on a different culture and able to care for them well enough, when really having cultural humility and knowing that we don't even know what we don't know to care for the people of different cultures is more appropriate and helps us listen and try to understand more. A language barrier is really unacceptable as a reason to not receive appropriate care. We need to provide appropriate resources for everyone, despite a language or educational barrier. Interpreter services need to be used, and I've found some of my patients may need longer or more frequent visits just to get a good story with an interpreter, and that just needs to be done. Many studies bring up racial matching of patients and providers to improve the problem. I absolutely agree we need to improve diversity in healthcare, but I'm not in complete agreement with this. I think it puts the burden on the Black and Brown communities to produce providers and care for their own, and it doesn't address the problem of racism. We are recommending children have ABA, sometimes 25 to 40 hours per week, in addition to physical therapy, occupational therapy, speech therapy, parent-child interaction therapy, etc., which are many more hours. Families need to have help with childcare, their jobs, and transportation to have access to these services in all communities. Referrals to specialists should be equally available to all children, and we need to include girls specifically, but other nationalities too, in autism research more. Telemedicine may be helpful for those geographically far from specialists to receive a timely diagnosis, but also those who have difficulty with transportation or childcare. Ultimately, we need systemic changes to make a difference in regards to racism, though individual efforts are important contributions, and we need to continue to bring awareness to these inequities. Here are my resources. And thank you for your attention.